Harvey A. Friedman and Doris May Hacker Friedman established the center more than 2 decades ago with a generous gift. Doris May passed away less than a year ago now. When she was still in St. Louis, she'd come to our conferences regularly. And when she remained in Florida, she tried to come in remotely as she could. This is our first lecture since her passing. So I am very honored that we are remembering her today. Her daughter, Lynn Hamilton, here. Lynn, if you would stand. Represents the family here today. And I believe that her other daughter, Leslie Friedman, is joining us remotely from San Francisco. So we continue to honor the Friedman family for all they've done. Here's what we're going to do today. I'm going to start with a brief update on the center. We're going to give out our awards, the best part of the year. Then we're going to turn to our topic of innovations in care for people with serious illness. You see the lineup of scholars and innovators that we have with you here today. And please don't be shy about questions. A big part of our program is going to be interacting with these experts on this topic. So a bit of background about what we've done this year at the Center for Aging. We continue to promote research on both sides of campus related to older adults and aging society. We're starting our 5th Summer Research Institute where undergraduates spend the summer studying in fields of gerontology and geriatrics. It's a grant from the National Institute on Health, and thanks to Brian Carpenter and Natalie Galusha for leading this effort. We had a great year in Issues in Aging seminar. We have speakers from the community representing important initiatives. Here we have Cheryl Whalen, who came and spoke to us about the National Research Center on LGBTQ older adults. And just this week, we heard from Patrick Hill. We also feature our researchers on campus presenting his work on purpose in life. Our secondary data interest group, we have one more session this year. Our most recent presenter was Krista Mulder from the Knight Alzheimer's Disease Research Center, who shared secondary data sets to study cognitive functioning. You're all invited to any of these events. Check them out on our website and in our newsletter. We hope that you can join us. We continue to advance our WashU for Life initiative. As you can see here, we're contributing to the literature, but we're also deepening our partnerships on this campus, deepening our partnership with the Academy for Diversity, Equity, and Inclusion, and with University College. We're exploring program development with U College because of their wider reach into the community. Our goal is to increase age diversity and age inclusion on campus. So we have been doing some data collection. We've been exploring other universities across the country who have specific strategies to widen the range of students that are at WashU in all the activities at campus. We're also running focus groups to talk about the opportunities and challenges of serving a wider range of ages on college campuses. Our work in this area has brought us more squarely to the topic of ageism. So we've been producing some resources for the community, for students, for faculty to use. It's on our website. We'd be glad to get it to you. We have an infographic that summarizes the knowledge about ageism, but we also have a longer detailed literature review available to you all on ageism, and the references that we use in that background paper are available to you as well. So that's on our website. We sure hope people take advantage of it. And Natalie and I have been able to do some presentations recently on the topic of ageism, how it hurts, and how to combat it. So that's what we've been doing at the Center for Aging this year. Oh, one more thing we're doing, I forgot to tell you. We've been working with University College to try to institutionalize our transitions to retirement program. We had developed this with support of HR at WashU and offered it as a 90-minute seminar before the pandemic, virtually through the pandemic, but we're trying to institutionalize it and make it a little deeper by offering an 8-week course to WashU employees and community members through the U College. We did a very successful course this semester. We're going to do it again in the fall. If you're interested or know anybody, please let us know, because we'd like to really build this course through University College. All righty. We now get to turn to our awards. Each year we solicit nominations, receive numerous impressive nominations and letters of support, and we convene a panel of stakeholders to be judges to select these winners. The first award is the Kapilo Award. This is given to WashU scholars who make outstanding contributions to the care of older adults through direct patient care, research, and in our case, it's usually both. We would like to thank the Foundation for Barnes-Jewish Hospital from the Aileen and Meyer Kapilo Fund for Geriatric Psychiatry and Neurology. I don't know why we had that break there. And this year's winner of the Kapilo Award is Andrea Denny. I'm going to tell you a little bit about Andre before we ask her to come down and receive her award. Andre leads the Outreach, Recruitment, and Education Core of the Knight Alzheimer's Disease Research Center. She is also a social worker for Washington University School of Medicine's Memory Diagnostic Center. Andre earned her BS in psychology from the University of Virginia and both her MSW and her law degree at the University of Texas in Austin. She joined the Knight ADRC in October of 2011 and the Memory Diagnostic Clinic several years later. She's also served as an active member of the Greater Missouri chapter of the Alzheimer's Association, where, among other things, she's facilitated support groups for caregivers. She's an instructor of neurology at WashU, and her nominator, Dr. John Morris, states that she possesses the insight and dedication necessary for academic research while maintaining the interpersonal and emotional intelligence needed to work with vulnerable populations. We are very proud to have her as a colleague here at WashU, and I invite Andre down to receive her award and say a few words.
Thank you so much. Thank you. Can you all hear me, I hope? Great. So thank you, Dr. Morrow-Howell. Thank you, Friedman family. Thank you to the Friedman Center for Aging for hosting this excellent event every year. I'm really looking forward to today's program. I am humbled by this honor provided by the Kapilo family and the BJH Foundation. Thank you. I am grateful to my family, friends, and colleagues for honoring me today with your presence. I am so happy that Dr. John Morris, director of the Knight Alzheimer's Disease Research Center, took a chance on hiring me over 10 years ago. Working for the last 10 years with my team, Murda Spencer and Jennifer Phillips, under the leadership of Drs. Mulder and Morris, has been wonderful. Later, after joining the Memory Diagnostic Center as a social worker, the urgency of the research to develop treatments, prevention, or cures that will benefit all has only become more urgent. If I started trying to name all the talented, generous people I work with, the length of time would get way out of hand, and I would unwittingly omit the names of very special people. I have such wonderful colleagues. Suffice it to say, I have learned a lot from so many, including my social work mentors, Becky Fierberg and Terry Hosto, those that trained me in my volunteer work at the Alzheimer's Association, and the patients and families I speak to every day. What they teach me, I try to share with others. I'm grateful most of all for that time spent with participants, patients, and families who have given me the privilege of witnessing a small piece of their lives. It is truly meaningful, even in the times when it breaks your heart. Thank you.
Thank you. Thank you, Andre, for those wonderful words. Our second award is the Friedman Award. This award is given to persons in our university or the larger St. Louis community for their outstanding contribution in service to older adults through practice, advocacy, and research. It's also supported by the Foundation for Barnes-Jewish Hospital from the Harvey A. and Doris May Hacker Friedman Endowment for Aging. This year's winner is Pamela Merkel. Pamela runs the Association for Aging with Developmental Disabilities. She has dedicated her career to bridging the fields of developmental disability and aging, and has tirelessly worked to ensure the health and dignity of people with disability moving into later life. She is an expert who is sought out nationally by policymakers and educators to better understand how to meet the needs of this important population. Her nominators, Jan McGillick, Kelly Barton, and Catherine Faraci, said, "The Aging Services Network in Missouri has indeed been enriched by Pamela Merkel's tenacity, positivity, and compassion for those who were once a hidden, forgotten, unempowered, and underserved group of elders that are now able to live healthier, more active, and self-directed life because of her work." So it's an incredible honor to have Pam here today to receive this award.
Thank you. Ooh, it's me, but it's not really me. So I do. I represent the Association on Aging with Developmental Disabilities, and I'm totally grateful for this award, for sure. Like, absolutely amazing. But I'm not by myself, you guys. I'm not. I have like the most amazing board of directors. I have the craziest, amazing staff who support people with developmental disabilities. I have amazing funders, like outstanding. And then it comes to the people that we get to support who have developmental disabilities. Why we even exist is because they didn't get to live into older ages, and now they do. And we in this room and the guys that are listening out there in the air, right? We're all trying to figure out how to support this amazing aging population into good quality, long, happy lives. So crazy successful. I mean, we're about collaboration and we're about education. So to be able to collaborate with you guys, I'm really excited about the information we're going to get today, because I will use it today in order to support people with developmental disabilities who are aging. The education component, here's a little blurb. Our 31st annual conference on aging with developmental disabilities is this year, May 23rd and 24th. If you guys want to learn more about aging with disabilities, we bring the best disciplines to the table in order to learn and be able to support people, because that's what we do, right? All of us here in the room, all of us in the air. So yeah, totally grateful for the award. Thank you very, very much. Thank you.
All right.
Yeah,
Thanks, Pam.
thank you.
Is that your glasses,
my
my glasses, my notes? Okay. All right, we have another set of awards. The Mark S. Wrighton Graduate Student Research Award on Aging. This award is now 3 years old. We established it in honor of Mark Wrighton when he retired, when he became Chancellor Emeritus at the university. He had started the Center for Aging. This award is to recognize doctoral candidates who show outstanding promise as researchers on topics relevant to older adults and aging society. They're chosen by an event where people who apply come and do a 3MT or a 3-minute thesis presentation. You're going to see the award winners, so you'll know how we do this. We have a panel of judges who are from different parts of the university and community, and we also have the audience voting for a People's Choice Award. So we have 2 awards to show you. The Judge's Choice, Hannah Maybreyer, and People's Choice, Lucy Capano. They're both here today to do their 3-minute theses for you. Hannah is a 5th-year graduate student in the lab of Dr. Denise Head. She's pursuing a PhD in clinical psychology. Her research interests explore how sleep and other lifestyle factors affect cognition. Her presentation is called Navigating Later Life. Can Sleep Help Us Find a Way? Our People's Choice winner is Lucy Capano, a fifth-year graduate student at the med school in Dr. Andrew Yu's lab. She studies tauopathies through direct conversion of human adult skin cells to neurons. You will enjoy her award-winning presentation on why capturing age matters, advancing our understanding of neurodegeneration. So Hannah's going to come up. Come on up. And I'm going to get her one slide. They get one immobile slide up to do their shtick and explain why their work is important.
Thank you. Have you ever come across a problem that you just couldn't solve and someone tells you you should sleep on it? Well, it turns out this is good advice for a lot of reasons. Sleep can help reduce stress, it can improve our focus, but also sleep can help us piece together information into memories. Unfortunately, as we age, both our sleep quality and our long-term memory abilities get worse. Older adults spend more time awake during a night and experience less deep restorative sleep. There's some evidence that shows that decline in memory abilities may actually be partially caused by these changes in sleep in older age. But this research mostly focuses on simpler forms of memory, such as the ability to remember a pair of words. What about more complex memory abilities, such as the ability to remember a spatial layout of an environment? Each day, we use this to remember the location of objects and places in our environment. For example, you might need to remember where your car is parked or where the train station is once you leave this event. This type of spatial memory is selectively impaired in older age. Older adults who report more difficulty finding their way are also more reluctant to travel to new locations. And this decrease in mobility can lead to reduced independence and lower quality of life. That is why understanding the factors that lead to this change, especially factors that we could change, like our sleep, is so important for improving our way of life in later years. The focus of my research is the relationship between age, sleep, and memory of a spatial environment. In an earlier study, I used a wrist activity monitor, similar to a Fitbit or an Apple Watch, to measure sleep in older and younger adults. And then I tested their memory. I found that overall, older adults had more difficulty remembering the spatial layout of an environment, but older adults who experienced more frequent awakenings experienced even greater difficulty remembering this environment. One potential explanation for this is that these adults who are waking more frequently are experiencing less deep restorative sleep. So my future research will use a device that detects electrical signals from the brain during sleep. From this, I can tell whether changes in brain activity in older adults predicts their ability to learn and remember a spatial environment. By gaining this knowledge, we are one step closer to understanding and preventing declines in spatial memory in later life. Hans Christian Andersen once said, "To travel is to live. Perhaps the key to living longer lies in a good night of sleep."
And this award carries a cash prize as well to support ongoing professional development for Hannah and Lucy. So thank you very much for that. Lucy, come on up. When the students compete, we're much more rigid about they get the hook at 3 minutes, so they're really well tuned on their time. Today's we're a little less stressed to show the great work that they're doing. There's Lucy's one slide, and there's the mic. Is that all right?
Can you all hear me?
Yeah.
Wonderful. So imagine this. When you're born, you're given a brand new teddy bear. It's the only one you get, and you have to use it your whole life. When you're young, it's you and Teddy hanging out. And as you age, well, Teddy starts to look a little worn. Now, this wearing of Teddy can lead to a catastrophic event, an unfixable hole. Now, I'm not really talking about a teddy bear. I'm actually talking about your brain. In my analogy, Teddy is your brain. That wear and tear is normal aging. And that catastrophic event is getting a neurodegenerative disease called tauopathies, the most common form of which is Alzheimer's disease. Alzheimer's and tauopathies affects 30 million people worldwide, which is equivalent to the entire population of the state of Texas. And unfortunately, we have tried for 30 years, and with over 150 clinical trials, we still have no preventions or treatments for this disease, and they are always fatal. So how can this be? We've spent so much time on this. I believe it's because scientists have been using the wrong teddy bear to understand. Let me explain. In our analogy, if we want to know what causes that catastrophic failure in Teddy, well, the best way to do that is with an old and well-worn teddy bear. Moving back to the real world, this would be an alive adult human brain. This may come as a shock, but that's pretty hard to come by. So instead, scientists make brain cells in a dish from stem cells. But here's the crux. Stem cells have the same age of a newborn baby. So if we want to know what causes an aged and worn bear, well, one that's right off the assembly line just isn't going to get the job done. This is where my thesis comes in. My lab has a method of generating old and well-worn neurons, brain cells, just like a bumped and bruised teddy bear. And with this model, we can then capture those old kind of worn events that occur to help us dissect the mechanisms of the diseases better. We do this by taking skin cells from humans and giving them two small guides called microRNAs. These change the cell fate, telling the skin cell genes to quiet down, allowing the neuron genes to come up, completely switching the fate to that of a brain cell. And when I made cells from patients who have a tauopathy, I was able to see the hallmarks of protein aggregation that never has been seen in a human model before. And so with this system developed, I hope we can dissect the mechanisms of disease to better inform our ability to make drugs and treatments to prevent these devastating diseases. Thank you.
So you can see the legacy of WashU researchers is a bright one, with so many of our graduate students participating in this competition. I'm sure Mark Wrighton would have been here, but he's being, as you might know, the interim president at George Washington University in DC, right? Yeah. I will be sending this tapes to him so that he can see the winners of his award. All righty. Couple of reminders. There's food and drink in the back. Please feel free to grab anything. We also are recording that you can get these presentations even if you're here when we're done today. So now we get to move on to our main event. We are so pleased to have Dr. Patrick White with us today. A few years ago, Dr. White was accepted the position as the division chief of the newly formed Division of Palliative Medicine in the Department of Medicine at WashU. The newer Division of Palliative Medicine was a collaborative effort between the Department of Medicine at WashU, BJC Healthcare, Barnes-Jewish Hospital, and the Foundation for Barnes-Jewish Hospital. And at this time, Patrick was recognized with the Stokes Family Endowed Chair of Palliative and Supportive Care. Dr. White received his bachelor's degree from the University of Notre Dame and his MD from The Ohio State, followed by his residency here at WashU and Barnes-Jewish Hospital. He then completed a palliative care fellowship at the University of Pittsburgh. He's been actively involved in clinical research to help reduce pain and nausea in patients with advanced cancer. He's the chief medical officer of BJC Home Care and leads Evelyn House, which you'll hear more about, a hospice house serving adults and pediatric patients and their families. Long list of accomplishments. I'm only going to name a couple. One, selected as one of the inaugural hospice and palliative medicine inspirational leaders under 40 by the American Academy of Hospice and Palliative Medicine. one of 7 physician leaders nationally selected for the inaugural Hospice Medical Director Leadership Council. He's received distinguished teaching awards here at WashU, and he serves this community through several important roles, including being on the National OASIS Board of Directors. So Patrick's recognized for his accomplishments, his leadership, his commitment to patients in their care, and we're very happy to learn from him today. Patrick? We're good?
Perfect.
Good. We've got your
Thank you.
mic. Good.
Thank you so much, Nancy. I have to admit that I'm a little bit jealous that I wish I had a teddy bear slide to kick off here. But in today's lecture, I get to do something really similar. For the last 5 years, I've been talking a lot about some of the problems in patients with serious illness at end of life. Today, I get to share some of the solutions that we finally have, and I have a panel of all-stars that are doing some of the most innovative work in the country. And so for those of you that brave the weather today, which is awesome, I think we'll have a chance to hear about some really innovative things that aren't being done nationally. So here we go. And so I am, I think, required by law to always do one slide explaining the difference between palliative care and hospice. And so palliative care is care that is an extra layer of support that can be given at any point in a serious illness. And so those patients may still be getting curative therapy like chemotherapy or surgeries or going back to the hospital. While hospice care is a government benefit limited to the last 6 months of life, so patients with a prognosis of 6 months. And that's care for people that typically want to be at home with their loved ones, and it brings a really high level of support into their homes, delivered by nurses, social workers, chaplains, and nurse practitioners. So I'm going to start out with a really quick question, because you're at one of the finest research institutions in the country. You heard about the amazing work of this duo. And so as you hear about that, it sometimes sounds like we have conquered the problems of serious illness. Everybody's just getting cured. So I'm going to do a bit of a reality check, which is, if you think back to the year 1980. So picture Michael Jackson, E.T., Pac-Man. You're back in 1980. And you think about a 75-year-old in 1980. And then you think about all these amazing advances, all the new PET scans, immunotherapies, the awesome cutting-edge research here. How much longer does that 75-year-old live now? And I'm going to cut to the beginning of COVID. Just for the sake of ease. How much longer? So I'm going to ask for hands here. How many of you would say 10 years longer? So are they living 10 years longer than that 75-year-old back in 1980? How many would say 8 years? 6 years? 4 years? 2 years? And the answer is 1.8 years. And a lot of that is due to the reduction in smoking. So as gung-ho as we are about these amazing cures and therapies, this is still an issue that we have to address. We have got to do a better job supporting these patients at end of life. And if you ask me, there is one clear, huge problem we have. Too many Americans are dying in the intensive care unit. When you compare us to the 7 other wealthy nations, we are more than twice as likely to be in the intensive care unit towards the end of life, twice as likely. That is not acceptable. So why is that? And my goal in life at some point, many of you may know, is to be a Family Feud host. That is what my calling is. It has not been realized. So I am going to use that now. Top 6 answers are on the board. Who will be brave enough to tell me why you think that is? Why are we dying in the intensive care unit at double the rate of other? Yes, thank you. Lack of education. And would you say, if we were to say on the patient end, the provider end, or both? Both. Great call out. Maybe better insurance. Better. Okay, insurance, we're not paying. Yeah. Okay. What are other reasons? Yeah. Oh, I thought yeah. Late diagnosis. We're not getting the information early enough about where we're at. Exactly. Yeah. Physicians aren't trained in end-of-life care. Well, you are stealing my thunder, this all-star audience. I should have known the people who would brave the weather like this. And for our 100 online, we can get into more answers. So my top 4, identifying patients earlier. We have done a terrible job at getting prognostic information early enough. We've got to do better. Supporting caregivers. We've got to enhance support for caregivers. And we'll get a chance to hear from one of the national experts in that as well. Creating equitable care at end of life for everybody. We are not supporting diverse populations the way we need to. We need to do better. And encouraging providers, training them in how to do compassionate and effective communication. So I'm going to go through a little bit about the problems and some of my own experiences. And then we've got the panel of experts that you're going to save all the really hard questions for, and you're going to drill them, and they're here with us. So why is this so important that we identify patients earlier? Well, this study followed 1,146 patients with lung cancer and colorectal cancer. And they followed them all the way till they died. And then they asked their loved ones, rate their end of life care. You know, was it excellent, good, fair, etc. 3 themes emerged for those that rated the care of their loved one as excellent at end of life. Would anybody be brave enough to give me one as I continue my Family Feud quest? Any guess? Yeah. Hospice, bingo. Number 2 answer. Great job. So what were they? Dying at home. Dying with at least 3 days of hospice care. You're setting a high bar up there. You're rattling off my talk. You were not planted. And then not being in the ICU in the last 30 days of life. When you're in that ICU, you rate the care of your loved one, only about 40% say the care was excellent, and we'll get into that. This is a busy slide, and you need eagle eyes if you can rattle it off, but I think one of the most important, so I'm gonna go through it a little bit. They asked 180 patients with serious illness to rate the states, these different disease states. So these are patients that were at least 60 years old and in the hospital. And they asked them, is it better than death, somewhat better than death, a little bit better than death, neither better nor worse than death, or the dark blue means that that state is worse than death. And they asked them about being in a wheelchair, being in moderate pain all the time, being at home, living in a nursing home, needing care all the time, needing a feeding tube, being confused, relying on a breathing machine, and being incontinent of your bowels and bladder, okay? I knew before the study was done, I knew that the majority of people would say living on a ventilator is worse than death. I mean, patients tell me that all the time. I was actually surprised how few patients said being in moderate pain all the time. People were okay with that. They were willing to tolerate that. What shocked me was how many patients said being confused all the time, being bedbound, and being incontinent of their bowels and bladder was worse than death, a very high proportion. And here's the problem. When we do our medical studies, we almost never provide this information. We look at how much longer you're gonna live. Very few of our studies are getting the things that people care about. So that's part of the huge gap. And there's a second piece, I think, that's really tricky with identifying patients. And this study opened my eyes by Dr. Christakis. It's over 20 years old. But what he learned is the longer your doctor knows you, the worse they are at predicting how long you're going to live. That surprises me, but it doesn't, because doctors are human too. And we build that emotional attachment. And it makes us tough for us to let go, even when we know we shouldn't. You know, my father said the worst decision he ever made in his medical career was with his own mother, and did aggressive things that didn't make any sense. And she died a really challenging death from her recurrent lymphoma. And this really hit home for me a couple of years ago. I do a lot of hospice, and I got a call from a hospice nurse that said, we've got a patient whose wife is buying stem cells on the black market and putting them in his feeding tube. The patient had advanced Parkinson's disease. First of all, I didn't know there's a black market for stem cells. Like, when I call you guys, where do I get a hold of black market stem cells? Second part is the science of putting them in a feeding tube is not very good. Okay, I'll just put that out there. But the part that really horrified me was I learned that this wife who was doing this had actually been a physician in another country. And it just showed me how that desperation gets in. And I learned two things. One, when we identify these patients, we need objective support tools to help us with it, because it's tough to pull the emotional piece out of it, even for healthcare providers. That's the first. The second is it just showed me, when you're a caregiver, how those emotions hit you. And so I'm just going to spend one slide on this, but caregiving is just not provided the support. 1 in 5 Americans, roughly, are the caregivers of an adult patient. And the percentage is increasing that are taking care of more than one person. So we're talking about over 50 million Americans. And you know, their health, as our population ages, their health is worse. And nearly a quarter of them say that caregiving made their health even worse. I see that all the time. I see our caregivers skipping their own doctor's visits, not exercising, losing social contact with their friends. The toll is huge. And yet, despite this, we are not providing them the support they need. So we're going to get in how to fix that soon. And then the other issue that's huge is we've got to support all people. You know, and there are groups that are falling through the cracks. A couple years ago, I took care of a patient, Mr. B, and he was 56 years old and had lung cancer. He didn't have a lot of financial resources. Housing was challenging for him. Flip through his chart. He, in the last 10 months, had 90 emergency room visits and a hospitalization. 90 visits in 10 months, just in and out of the emergency room in the hospital. You know, and I was talking to him about his journey, and, you know, that other patients of color like him, that it's often tough for them to receive the desired intensity of care and the support they need. How do we fix that? And it's true for patients who don't have the financial resources. Navigating our healthcare system is such a challenge. How do we fix that? And some of the incentives make no sense. We have so much room to improve and to get these incentives to better realign with the care we actually need. So this really struck me, that they did a study that showed that when a patient goes from the intensive care unit, which I've said is the devil, basically, for patients who are dying at end of life, and we move them in to an inpatient hospice house, we do a couple of things. One, their satisfaction goes from 40% nationally to the satisfaction at our hospice house, Evelyn's house, 97% of families are satisfied. 97%. So even patients who are there one day have a much greater satisfaction with care being in a more home-like environment. It makes all the difference. I have to call out our foundation, the Barnes Jewish Foundation, for making that possible. And what they did is listen to one of our donors, and she was with her sister who died in Sweden. And she said they were in a home-like setting where they had a community of patients who were seriously ill. And it felt so much more natural than any death she'd seen in America. And that's when she decided to come back and institute change. For me, the hardest part of my job is when patients feel better in the hospice house telling them they have to leave because the government cuts off reimbursement. The government does a great job of reimbursing for surgeries, for chemotherapy, a lot of procedures, and in the intensive care unit. They try and have us move patients out of the hospice house. The national average is 5.5 days. Even if they're actively dying, they will cut off payment. Most of the hospice houses, including our own, run at a huge financial deficit, and it's only because of donors we get those outcomes. Yet they've announced for us a new set of denials for those payments. So I'm hoping, I see some wizards here who know advocacy. This is something we've got to fix. It just feels wrong. And again, just for on that last slide, it saves on average $7,000 a patient, not to get into the financials, but for each patient transferred over. So it just makes such sense to fix that. So I can't blame the government for everything though. And as it was called out by multiple people, providers, we have to own this. Doctors and nurse practitioners need to do a better job with communication at end of life. And we can do it. There are ways to do it. This study really highlighted it for me. 4,000 patients, 4,000 physicians were asked, if you hit a patient in the last 4 to 6 months of their life and they weren't having active symptoms, what would you tell them? What information would you give them to help them with their planning? And only 2/3 would be willing to talk about end of life immediately, and less than half would talk about CPR or being on a ventilator. And only 1/4 would talk about hospice care. We've got to, somebody called it out earlier, we've got to get that information so that patients can really start to plan so they don't end up there in the last minute. I love this quote by Dr. Nancy Keating. These conversations are time-consuming and difficult. Some doctors may feel patients may lose hope. It's easier to say, let's try another round of chemotherapy instead of having a heart-to-heart discussion. That is so spot on. And we'll get into that in just a second. The other piece we're not doing is giving people the information to the question they're really asking. So when you come into the hospital, and I'm your doctor, and I ask you if you want CPR or to be on a breathing tube, should you decompensate? You might say, well, doc, tell me more. What are my odds? What are my chances? It's really common for me to hear the doc say, it's a 50-50. And when they're saying that, what they're talking about is true. If you have a cardiac arrest in the hospital, about half the patients, their heart will start beating again. The problem is this. That's not what you're asking. You're not saying, can you get my heart beating so that a week later I die in the intensive care unit? What you're really typically asking is, am I going to be able to go home? And what's that going to look like? And survival home, you're talking more like 10%. 1 in 10 patients are going home and alive at 30 days. And when you look at patient populations, so 80-year-olds from a nursing home, anyone want to guess how many of them are alive at 30 days? Yeah, somebody's calling it out. About less than 3%. So it is frustrating that we're not getting that information to patients. We've got to do a better job. Today, Dr. Odom's going to fix that for us. And so before I turn to the panel, I think one story really put this all together for me. I had just been married. This was like 3 weeks after my wedding. And my wife was also a physician trainee. We were both interns. It looked like Grey's Anatomy, right? When we kissed goodnight, everybody thought we were up to shady business, but we were married, totally legit. So my wife was doing a procedure and her glove got split open and she got blood from the patient on the cut. And the patient had AIDS. And so they started testing her. They put her on anti-HIV medications and they start testing her. And each night when they tested her, they'd call us back and they'd say, your test result was negative. Well, 3 months is when you're the most likely to convert and to develop HIV if you're going to test positive. That's the most common time. So when she went to the 3-month test, we didn't get a call that night. And we know that when you test positive, they ran a confirmation test. They did a Western blot then to make sure that you really tested positive. And that night, I did not sleep a wink. My whole world was shattered. I thought, is she gonna wanna be a doctor now? Do I wanna be a doctor now? Are we ever gonna have kids? Our whole future vaporized before my eyes. This is, by the way, the only good family picture we've ever taken where the whole family smiled. And God pointed that out by putting rays of sunlight. It was really dramatic because everybody smiled, even my parents. So when that happened, it let me see into that window of what it's like to be on the other side when we have these discussions and share this information. It let me see how a simple thing, even just the lack of one phone call to let me know everything was okay, which happens millions of times, that wrecked my whole world that night. And I'd never been as scared as that. And so, I put my whole career into working on some of these issues. This is my second Friedman lecture. I am so grateful for this opportunity. It's just amazing that you have done this. But today we get a chance to talk about some of the ways that we are fixing these issues. So I'm gonna stop now and get a chance to answer some questions. I've got the A team. It took every ounce of willpower not to put a picture of Mr. T up to close the lecture. Instead, I know. Instead, I put, this is La Crosse, Wisconsin. And they've done a really proactive job about end-of-life care and having these discussions and normalizing these discussions. They were voted Forbes magazine's best place to die in America. Yes, exactly. You guys are in awe of that. And if we could bring that to St. Louis with your help and work on some of these advocacy issues, I've got the dream team panel to go through this. And I look forward to your questions. Thank you so much.
Thank you, Patrick. Thank you so much. I'm going to ask Brian Carpenter to join up front. He's got the hardest job of the day. Now he's going to be moderating all your questions and introducing and moderating questions for the panel. Brian Carpenter is professor of psychology and brain sciences. He studies family communications and decision-making, especially around issues of care arrangements and end of life. He's a beloved teacher and mentor. I have the pleasure of teaching a freshman class on aging when I'm 64 with him and working with him on projects at the center where he's the lead faculty for education. So thanks, Brian. Come on up and get some questions. Handheld for you.
Probably realize already that Dr. White really doesn't need an MC or a Bob Barker up here. He's pretty comfortable dealing with an audience, but my job today is to keep us in touch with the 77 people who are out there in the internet joining us on Zoom today. They're going to be asking questions that will feed in here, and I'm going to feed them out to Patrick, but we also are really interested in hearing your questions as well. We've got a few minutes before we're going to take a break. So does anybody have any initial questions for Dr. White? Yes, ma'am in the back row.
Oh my gosh. I should add on, the next day they called us back and my wife was negative. That is a very important part of the story. Thank you for that. Good call out.
Anyone else? Yes, sir.
So did everybody hear that? But are we ever going to talk about the day where palliative care is further up the line and we have a true continuum of care? And I hope so. That is our mission. I see in the audience, we have one of the godmothers of palliative care, Dr. Schultz, who really brought it to St. Louis. And I think we've had that dream for some time, that we get to that point where we're truly getting people upstream. I think one of the things in the panel is Dr. Moore is going to show a very innovative way that we can identify people much further upstream potentially and get them support earlier. Absolutely. So I'm going to say yes.
Patrick, I'm going to ask you a follow-up if you don't mind
Yeah.
on that. So you started out your presentation by talking about the difference between palliative care and hospice,
Yeah.
important educational moment there. Could you talk a little bit about your experience with providers and the extent to which even they need to know more about that distinction?
Yeah, absolutely, Brian. I mean, and there have been studies over the years, a huge percentage of physicians and nurse practitioners even don't understand the difference between palliative care and hospice. I mean, there's some studies, 30% do not recognize that difference. And that with palliative care, that it's just that extra layer of support. I like to think of it, we got a younger audience in general, but did any of you have a doctor that ever came out to the home or have a doctor with the infamous black bag? Yeah, okay, so we've got a few brave souls. So, you know, that doctor would help pull the information from the others. And as medicine has gotten more specialized, we've gotten away from that a little bit. And I think sometimes it's not always clear, is it the oncologist or the cardiologist or the primary care doc calling the shots at end of life? And it becomes blurred where you don't get the big picture sometimes. So helping to educate other providers is absolutely critical. And there are still a lot of challenges.
Okay, thank you. Anybody else? Yes, Michelle.
Yeah. So I love this question for Dr. Schultz because today we have the answer for you.
Patrick.
And Dr. Moore is going to get into some of the new machine learning techniques that help us to identify patients and do a more robust job. And so, perfect. Good lead. Yeah.
Are all palliative care programs the same, no matter hospital-wise, community-based,
Yeah.
or not?
So that is a great question. And the answer is no. There is a ton of variation among the palliative care programs in terms of how they operate, what services they offer, how much you have to pay for it. So hospice tends to be very standardized no matter where you go. It's very similar. Palliative care is not. That's such a good call out. We could be talking about 10 different things, and that's very confusing, I think, for patients and families, because they're like, wait a minute, I heard this could be a part of it. It's some programs, yes, it's some no.
Patrick, we have a question that came in from one of our colleagues on Zoom, one of our nurse colleagues, who asks, to what extent does culture play into the US not doing well with end-of-life care? For example, some other cultures have a broader definition of what constitutes a family.
So that is great. I'm totally going to punt that question to Dr. Keisha White, who's going to be talking about health equity. Because that is exactly what she's going to get into, or some of those differences and what that looks like.
Stay tuned. So we've got time for one more question before our break, Emily?
Yeah.
Is there research that shows the difference between people being content with dying at a hospice house like Evelyn's house versus at home?
So the question I think you heard was, are there studies that talk about the difference between a hospice house and at home? It is so funny you say that, because we are working on that right now. And I think that's part of the problem, is that there is relatively, in the hospice world, we have ginormous hearts, but there's much less research that goes on, and the government hasn't made funding for us a priority. Palliative care and hospice get roughly 0.1% of the government's research budget, if that. So it's been, we need those studies exactly to show the impact. And I know just the team who's working on it right now.
Thanks for these questions from everybody. We're going to have more time for questions, ample time after we take our break. So we've got a really exciting second half of our program this morning. You can tell already that we've got a panel of very well-dressed, attractive experts who are here to share an amazing amount of information with you about some of the ways in which they are transforming end-of-life care, care for people with serious illness here in St. Louis. So we are going to be the best place to die in the United States eventually. I don't know how well that translates to a t-shirt or a bumper sticker, but I'm not sure the Chamber of Commerce will want that as a tagline, but we'll see what we can do. So we have a series of 4 presentations this morning from each of our panelists. They'll come to the podium, talk to you a little bit about some of the ways that they're transforming serious illness care here in St. Louis. We'll have time for a couple of questions for each of them at the end of their presentation, whether from our audience or our Zoom audience. And then once we make our way through these 4 panelists, we'll have ample time to answer more questions, engage in what we hope will be a lively conversation with you and amongst themselves about the future of end-of-life care. So I'm going to start out by introducing each of our panelists before they come up for their presentation. And our first panelist this morning is Dr. Karla Washington. Dr. Washington studies interventions designed to promote the biopsychosocial, spiritual, and cultural well-being of individuals, families, and communities experiencing serious and life-limiting illness. Much of her work utilizes digital health solutions in the related fields of hospice and palliative care. Dr. Washington currently serves as principal investigator for a number of research studies focused on improving outcomes for family members and friends who provide care to seriously ill adults, with a particular emphasis on individuals from rural and underserved communities. This body of work, funded by entities such as the National Cancer Institute and the John A. Hartford Foundation, has been described in over 120 peer-reviewed journal articles, which Dr. Washington has authored in partnership with colleagues across the country and closer to home here at the Washington University Lab for Innovation in Palliative Medicine. Please join me in welcoming Professor Karla Washington.
Because I have in my bio that I study digital health without fail, something's going to go wrong technologically. That's how the universe and I interact. So I appreciate any grace you're able to extend this morning as we get started. I was going to start a bit unconventionally and offer a book recommendation, and the reason will be clear in just a moment. But on this slide is the cover art from a book that I've decided is my favorite I've read since the start of the pandemic. Does it look familiar to anyone? Anyone else read the book? It's called Sharks in the Time of Saviors. And I read it with a group of friends and I was blown away. And they all liked it very much and would certainly recommend it. But I showed up to this online book club, suggesting this was the most important piece of literature that had been written in quite some time. And everyone was pretty surprised by my assessments, and I couldn't figure out why it really spoke to me. And then this morning, I was connecting the dots and wanted to share with you an observation. So this book describes a family that's sort of messy, and many of us, certainly I can relate. And they face a lot of stressors and challenges, but at just the right moment, time and again in this story, people are getting evicted, the police are showing up, it looks like people's interpersonal relationships are about to fail. And then in a sea of people who are just bringing stress and challenges, their families there. And I love this idea that just when we need them, what it means to be a family, what it means to be a caregiver is showing up for one another. So I'm really delighted to take just a few minutes this morning and share with you the phenomenal work that we're really excited about in our lab in the Division of Palliative Medicine here at Washington University in St. Louis. I don't have to spend a lot of time convincing you to care about families. Dr. White did much of that this morning, but I'll remind you briefly that in addition to clinical wisdom, we also have decades, perhaps centuries in some respects, of research that really highlights the fact that patient and family quality of life are powerfully interrelated. And of course, in much serious illness care, family members are both co-providers of care, so they help, and in some respects do the day-to-day heavy lifting of caring for people who are seriously ill. But also in hospice and palliative medicine, they're regarded as co-recipients of care. So we have a formal obligation to also care for the well-being of patients' families. So the first study I'll mention has a terrible acronym, and they only get worse. So the first study I'll highlight of two that we'll talk about briefly this morning is called Pisces, PC. And Pisces stands for Problem-Solving Intervention to Support Caregivers in Everyday Settings. And the PC refers to the fact that this is a study that takes place in outpatient palliative care. Basically, the background here is we know there are millions of Americans who care for someone with a serious or advanced form of cancer, and they face significant stressors, which put them at heightened risk of anxiety, depression, poor physical health, and Dr. White had much of that information in his slides, and compromised quality of life. So with the generous support of the National Cancer Institute, we're running a 5-year multi-site randomized clinical trial of problem-solving therapy for family caregivers. We're 8 months in, and I hope this is real wood, because every time I say it out loud, someone on my team tells me to knock wood. Things are going exceptionally well. Washington University is just incredibly fertile, provides fertile soil for research. So we're really delighted to be doing this work here, and are excited to see if in fact our hypothesis that Pisces decreases depression and anxiety and increases positive aspects of caregiving proves true. Also very excited, and you'll meet my colleague, Dr. Keisha White, in just a moment. We very recently have applied for additional support that would allow Dr. White to lead a portion of this study focused on understanding differences in problem solving and decision-making among diverse caregiving groups. And then finally, we have an aim on this study. It's going to help us understand how best to take this intervention, this supportive therapy, and actually get it to the family caregivers who need it. In family caregiving research, we have literally hundreds of evidence-based interventions that are sitting on shelves gathering dust, much of which was paid for with your tax dollars. So we're going to solve this problem and figure out if in fact there's an evidence base for this intervention, how can we get it to the people who need it? This is a quotation that speaks to me really powerfully. It's from a participant who received the Pisces intervention in a prior study. And she indicated that Pisces helped her think through things instead of just feeling everything, which I love as a quotation, because when I personally am overwhelmed, that's what I'm doing, is just feeling things. And this is certainly how we hope Pisces helps families. I have an enormous and brilliant team. I feel sort of overwhelmed with gratitude when I get to see the names of all of the people we get to work with on this project. Happy to have the list grow. If you're interested in becoming involved, please let me know. So that's sort of the big boy, and I'll introduce you to a new kid on the block, and I warned you that the acronyms get really bad. So the next project is Envision, which I've decided can technically stand for Engagement and Visualization to Improve Symptoms in Oncology. And this is work we're moving forward with the generous support of the Healthcare Innovation Lab and Washington University Institute for Informatics through their Big Ideas program. And I think I applied for that maybe on my second day here in the faculty. I was really, really excited to have this mechanism to move forward projects in really a developmental stage. The background here is that we've studied for many, many years in hospice settings, and Dr. White gave you that slide that distinguished between palliative care and hospice. So these are individuals who are nearing the end of life, many of whom are receiving care in their home. And we know that family members in those settings often really struggle to manage pretty complex symptom management tasks. On the other side of the coin are hospice interdisciplinary teams that want nothing more than to provide really excellent support for pain and symptom management in the home. And to do that, they really need up-to-date symptom data to inform care planning. The other context we didn't talk about this morning very much is that we, in all aspects of healthcare, and hospice and palliative medicine is certainly not an exception, are facing a workforce shortage. And so really a lot of these teams are working with large numbers of patients, onboarding new patients at an unprecedented pace. So we've developed a tool that's very much in progress. I have a couple screenshots I wanted to share with you really briefly. We have a website. You can go there and not log on, but if you want to knock yourself out, you can look at that picture. But the idea is that patients and families will be able to log on to an app, or it will be accessible via web as well. And this slide is really just for the patients. We are also going to have a second slide that asks for the caregivers to report information. But the idea here is every day, a patient, or if the patient is too ill, their family member will be able to go online and submit information about, for example, pain is the first item on the screen. You can complete this once patients and families are able to do assessments fairly quickly in under 2 minutes. So we'll have patient information. We'll have information on family members, really breathing life into that philosophy that family members matter too. We're creating data visualization with information scientists that will allow family caregivers and hospice interdisciplinary teams to see at a glance where patients and families are struggling so they can provide appropriate support. Our team is smaller for the Envision, small but mighty, but we also welcome partnership here. And I should mention specifically the Platform STL team, our local vendor here in St. Louis, who have been phenomenal in building this with us. So what's next for Envision? We're going to do a feasibility study this summer, working with some local hospices and making sure we work out all of the kinks, refine the tool as needed. Then we're really teed up for some efficacy testing. We would like to move this work forward in a large scale trial. The acronyms get progressively worse. So we're also looking at some adaptations for Envision with Envisioned, which is a tool we're tailoring for individuals who have dementia, because we know they communicate about their symptoms very differently than other types of patients. And looking at how Envision may or may not be helpful at other points in the disease trajectory as well. I'll close by saying we want you. If you're interested from a research perspective, from a clinical perspective, educational perspective, if you'd like to support this work and be a part of our team, please let me know. I'm at kwashington@wusel.edu and I'm around all morning. Thank you.
Yeah. So we've got time for a couple of questions for Dr. Washington from either folks on Zoom or here in the room. Panelists, you're allowed to ask questions as well. Nancy?
Thank you, Karla. What is the biggest problem when you're teaching families problem solving? Could you identify what are the top 2 or 3 things they want to solve a problem around? Is it pain? Is it feeding? Is it, what is it?
So we have a lot of symptom management issues that arise. A really interesting phenomenon happens. We have an interdisciplinary team of interventionists, and even though they don't always disclose their discipline, anecdotally, when people are working with a nurse, they bring up pain and symptom management issues. And when people are working with a social worker, they bring up more psychosocial issues. And I don't have any idea how that's happening. We audio record all of these. So there's some magic happening we don't fully understand, but we get a lot of pain and symptom management issues. And then some psychosocial issues. And the one that comes to mind, it's an older issue, but for example, there was a gentleman whose wife had breast cancer, and his mother-in-law, so the woman with breast cancer's mother, had moved into their home to help. But this individual, the mother-in-law, was incredibly anxious. And the gentleman with whom we were working perceived that that was making other people in the house more anxious. And he basically wanted her to go home, but loved her very much and loved his wife very much and wanted his kids to have the love of their grandmother. And so he was trying to really develop a plan to at least initiate a conversation about whether she could go home, whether she could take the kids, for example, out for an evening, and he and his wife would have some time. So they really wanted to sort of return to some form of normalcy, and he tried to have that conversation really get started. And so that's how he used that. We've absolutely had people who've had individuals with dementia who are awake at night and have been able to tap into resources to identify from some of the wisdom of people who've been caregiving for a long time. We also have some incredibly innovative solutions that we disseminate through publications of people who've had some pretty homegrown solutions to the problems they face. And so there's just this premise that people who are facing a challenge are often best equipped to solve it, but we also want to offer them that appropriate level of support.
Patrick.
Dr. Washington, would you talk about social media, how that has impacted your work?
So much. So we have a number, we have an interdisciplinary lab and a number of projects that are led on social media. And Dr. Deborah Parker Oliver is a part of our lab and is a principal investigator on some of that work moving forward. It's been really interesting to, I'll use the word reconcile, and that's maybe a bit dramatic, but to deal with and respond to the fact that people are putting a lot of information out on social media, gaining a tremendous amount of support. It's absolutely a community that is very literally a social network. And I think in some ways, we're certainly getting a lot of support, and in other respects, maybe dragging people kicking and screaming to the realization that we better figure out how to help people use social media in constructive ways instead of acting like it doesn't exist. And instead of letting policies that are designed to protect patients and families' privacy be a barrier to them getting the support they need. And so much of that work at this point is really focused on digital literacy and helping patients and families really make informed choices about what they share, but really empowering them to make the decisions about if and how they'll exchange information online. But social media is absolutely potentially a next wave in terms of how we support family members, and in some respects has been that way for a very long time.
Karla, do you mind if I ask you a question about family?
I would love it.
Question we had before our break was about different definitions of family. And so could you talk a little bit about how you've been thinking about family? Because family looks a lot different for different kinds of people.
Family looks very different for different kinds of people. And I'll also mention how lucky we are to have our most recent colleague at our lab, Dr. Jackie Benson, who's a family scientist who actually has master's and doctoral degrees in understanding what a family is. And so I thought I had it figured out, and she's really challenged me to think more deeply about these subjects. In our work, when we study families, we think about families as patients define them. So it can be friends or family. We don't really rely on that legal or biological relationship. And we're so excited to have Dr. White joining our team because she's going to be looking at how people think about family in different ways based on different life experiences and backgrounds. At this point, I'm very comfortable with people self-defining who family is and telling us what that means when they show up for one another, but actually defining that in a way that makes sense for policy, that makes sense for moving some of these interventions into practice and identifying who we want to support. It remains a really important issue in the field.
Great, thank you very much. We'll come back to Dr. Washington during our big panel discussion. I think you're pointing out such an important aspect of implementation. You know, we do a lot of great research, but how do we get these things out into the community, the people who need them? Thank you very much. Okay, moving on next to Dr. Keisha White. Dr. Keisha White is interested in understanding the racial and ethnic health disparities and promoting health equity in patients facing serious illness. Dr. White graduated from Vanderbilt University, where she studied sociology and medicine, health and society. She earned her Doctor of Medicine and Master of Public Health from the University of Connecticut. And Dr. White completed residency training in pediatrics at Texas Children's Hospital and fellowship training in hospice and palliative medicine at Children's Mercy Hospital. please join me in welcoming Dr. White.
Good morning, everyone. So as Dr. Carpenter said, I'm one of the junior faculty members, just recently joined this past October. So happy to be a part of the WashU family and hoping to make some connections with you guys today. I take care of children over at St. Louis Children's Hospital who are a part of our pediatric palliative care team, which we call Pediatric Advanced Care Team. And on that team, we take care of children with serious illness, children who've been diagnosed with cancer, congenital heart disease, prematurity and its related issues, neurologic diseases, and really follow them over the lifetime to provide support and assistance with decision-making and advanced care planning. In addition to that, I also have very much a passion for thinking about and researching and addressing racial and ethnic health disparities for both children and adults with serious illness. And it's my privilege today to be able to lend a little bit of a health equity lens to our panel. I'm going to take a few moments in my talk to just briefly introduce some of the disparities that are being actively discussed in the literature and at academic centers. I've chosen to focus on disparities in pain management, disparities in advanced care planning, and differences in workforce diversity, because I do think those are three pillars that are important in caring for patients with serious illness. And my hope is that we'll all take a moment here and just think about how we might intentionally include equity as an aim in all of the research and clinical endeavors that we're all doing for patients here. Okay. So pain management, as we've heard throughout the day, pain is one of the most common symptoms that patients with serious illness experience, and it's important for us to be able to support them equitably and to make sure that everyone has access to pain management. So I'm just going to highlight a couple studies that I felt were interesting and engaging, and you can find all of the studies at the QR link on the screen. So the first study was looking at patients who came into the emergency room with kidney stones, which if anybody here has ever had a kidney stone, you know it is like death, you feel like it. And so one would expect and hope that you would get a few pain medicines at the emergency room. And so this author looked at Black, Hispanic, and white patients who had been diagnosed with renal stones and whether or not they received pain medications, and showed that Black and Hispanic patients were receiving significantly less pain medication. Similarly, if one gets into a traumatic situation and goes into the hospital for that trauma, one would also hope that they would receive pain medication on discharge. Schwartz and et al. Looked at patients who presented in San Francisco after a trauma who were admitted. So these are patients that are fairly sick trauma patients, and looked at when they discharged home, whether or not they went home with a prescription for pain medication or not. And they wanted to compare patients who are English proficient and patients who have limited English proficiency, which I think is a unique angle in the literature that hasn't really been thoroughly assessed. And they found that patients who were English proficient were significantly more likely to receive an opioid prescription. In the pediatric literature, because I couldn't be a pediatrician and not talk about something pediatric related, we looked at kids who had broken bones and came into the ER. And one might imagine that breaking a bone can be painful, especially in getting x-rays and getting splinting done. And so this author wanted to look and see whether or not there was a difference in pain medication and pain relief for children who had documented fractures in the ER. And they found that minority children were less likely to receive any opioids and also less likely to receive adequate pain reduction, which they quantified as pain going from severe or moderate to a minimal or no pain. And then lastly, I just wanted to highlight a couple studies that are more focused on serious illness, end of life care. And I think these are two of the more robust studies that I found in this area, and it highlights some of the limitations and hopes that we here at WashU can be able to fill some of these gaps in the literature. So the 2018 study looked at nursing home patients all across the country who were diagnosed with cancer and took data from their initial admission to the nursing home. And they're supposed to record on their minimum data set on admission a pain score for every patient. And this author wanted to look and see if there was differences in whether or not a pain score was recorded and whether or not pain medication was being utilized for Black versus white nursing home residents. And what they found was that Black nursing home residents with cancer were less likely to receive any sort of pharmacologic pain management compared to white nursing home residents. And then this last study, it just highlights some of the limitations that we have and the information that we have. This study looked at 64 cancer patients, about half Black and half white, and also wanted to look at whether there were any differences in pain management. And they were not able to find any differences in their study. Speaking of advanced care planning, I think we've heard so far today, advanced care planning has pretty much become the standard of care for patients with serious illness. We want to have these conversations early. We want patients to have information about their disease and their prognosis and to be able to make decisions before we're in an acute crisis. And so to look at the literature on advanced care planning and disparities, there's actually a fairly decent amount of literature on this topic compared to others. And it's fairly well documented that Black patients in this country in particular struggle with completing advanced directives and having advanced care planning completed. This study here from last year, I just wanted to highlight that looked at Californians and whether or not they were able to complete advanced directives, and found that white patients were 50% more likely to have an advanced directive completed. They also interestingly assessed in this study racial and income discrimination and how that affected advanced care planning. This study, I think, just highlights the diversity of our country, and as we become more of a diverse country, thinking about what other populations should we be talking about other than just Black, white, there's, Hispanic, there's Asian populations. There are so many different people who have different cultural backgrounds that we need to consider and how we deliver culturally appropriate care. In this study, they looked at Chinese Americans and white Americans in Boston who had stage 4 cancer and wanted to assess based on clinicians, the actual clinicians caring for these patients said to researchers, hey, we have noticed that a lot of our Chinese American patients were having difficulties getting advanced care planning done. And so they did this study to look at differences and see what was going on there. They did not find actually many differences in frequency of advanced care planning or code status changes. But what they did discuss was that Chinese patients were much more likely to have family present for their goals of care discussions. And so it was a nice discussion about culturally how we make decisions as a family unit may be different for some cultures compared to others. And then lastly, this study I thought was very interesting, looked at Black patients who were receiving hemodialysis, so had end-stage renal disease, and whether or not they had started advanced care planning conversations. And they interestingly found that most patients, 68%, had not ever had a conversation about end of life since starting dialysis, which we know that the mortality for dialysis, 5-year mortality is significant. And the small number of patients that did report having end-of-life conversations, those conversations were happening with their primary care physician as well as their hemodialysis social worker. Workforce diversity, I think, is something that we are starting to recognize as an important factor for moving forward for care for patients with serious illness. But I don't think that we're quite there yet. And so I think we need to continue to talk about how we can help the workforce to match the population that we serve. This particular graph that I have here was published in 2021, where they looked at all of the top 10 healthcare professions and compared Black, white, Hispanic, and Native populations. And the blue vertical line that we see here represents the population percent. So for the first chart on the left, that's about 12%. That's the Black population in the country. And then the bars are each particular healthcare group. So we have respiratory therapists, nurses, pharmacists, advanced practice nurses, physicians, physician assistants. And that represents the percentage of that particular profession that is Black. And so we see that for every single group, there's less representation than what exists in our natural population. And then similarly on the right side, the graph for Hispanics, that gap is even further for us. And then just talking about kind of hospice care, we think about our population here in St. Louis and in Missouri. We have a fairly diverse population here. Patrick White was a part of a study where they did a survey to look at hospice providers, hospice physicians and nurse practitioners quite recently, and found that only 1% of the physicians and nurse practitioners identified as African-American. And so that was one person that, you know, is theoretically caring for all of the patients, you know, in our state. The story does not get much better if you think about training. If you look at the data for hospice and palliative medicine fellows, the last academic year, there were a total of 401 fellows throughout the country. Of that, 22 were African-American, so about 5%. 20 self-identified as Hispanic, which is also about 5%. And we had a total of 1 Native American person in the country who is going into hospice and palliative care. So I think we really have to spend some time, you know, as we go forward, thinking about how we can help our workforce to look like the community that we're serving, particularly because there's data now that suggests that having that congruence of race, ethnicity, gender, socioeconomic status is helpful and beneficial for patients and their outcomes, and also beneficial for our team dynamics and bringing new ideas to the team and how productive we are. So I just wanted to kind of introduce those as a few topics to consider for everyone here. I think as a new faculty member here, I'm hoping to get to engage in more research. As Dr. Washington was mentioning, I've applied for some funding to be able to look specifically at Black family caregivers and how best to support them in their decision-making, including considering how family structures might be different and how that might impact their decision-making. I've been very privileged to be able to collaborate with Dr. Patrick White and Dr. Parker Oliver here as well. And I look forward to working with you guys.
Thank you, Keisha. We have time for some questions. I suspect that our award winners were maybe interested in this presentation in particular because of their interest in special populations or smaller populations, unusual populations. And I was wondering if you could talk a little bit maybe about your understanding of intersections of identities. It sounds like the racial and ethnic factors are very important, but I wonder what happens when you put racial and ethnic minority on top of developmental disabilities or on top of dementia, or even combining gender and race and ethnicity and immigrant status. And are those just compounding the problem when you start thinking about those subgroups?
I think so. I think that we don't have that data from this specific palliative care population. And so I think that would be an excellent study to look at. But we know from other disease processes, you know, having several social risks, I guess I could say, does worsen your outcomes. And so I think you're right. We're all unique individuals and we all have different sort of spheres that we exist within. I exist within my race, I exist within my gender, I exist within my profession, I exist within my family. And all of those things do come together to impact how we experience the world and also how we experience our healthcare. So.
Yes, Jan.
Since the lack of workforce really permeates our ability to translate research into practice, are there some innovative programs? I mean, geriatrics has had this problem for years, but what are we doing to get more people interested in being palliative care practitioners?
So that is an excellent question. I think the overall answer is probably not a whole lot right now. I think there are some innovative programs out there. Pittsburgh specifically has a program to try to recruit and mentor young residents and fellows who are interested in palliative care to be able to do research who represent underrepresented backgrounds. I would love to start a pipeline program here. That is on my vision board, next 5 to 10 years, to really have a built-in program where we are intentional about looking for people who represent our population and engaging them and becoming interested in caring for these patients. And as you guys know, as a pediatrician, I see a lot of kiddos with complex chronic conditions. Those kids are going to be adults in 20 years from now, and they're going to be in everyone here's service pipeline. And so we have to start thinking about how we also engage people in that process as well.
Thank you. Thank you, Keisha.
Thank you.
And our next presenter this morning is Dr. Nathan Moore. He is a practicing internist with the BJC Medical Group and the medical director of the BJC Accountable Care Organization. And in his role with the ACO, Dr. Moore is responsible for improving healthcare outcomes and reducing costs for more than 70,000 patients. The ACO has saved Medicare over $50 million in the past 5 years alone. He's also the author of The Healthcare Handbook, a clear and concise guide to the US healthcare system. That's amazing that you wrote a clear and concise guide to the US healthcare system. Very inspirational. That's amazing. A best-selling book on the American healthcare system that has been featured in the New York Times, NPR, and other media. Please join me in welcoming Dr. Moore.
Thanks for having me. This has been a wonderful event. I just wanted to give a little snapshot into a project that we've been working on here over the past couple of years that's relevant to a lot of the things that we've discussed today. So just as a bit of background, although for the reasons that Dr. White and others have mentioned, end-of-life care is critically important and it benefits patients and families. We traditionally have not done a very good job of it here and at BJC or WashU for a number of reasons, and we're unfortunately not unique in that perspective compared to other places across the country. For a variety of reasons, a lot of which has to do with the healthcare reimbursement system. As Dr. White mentioned, invasive procedures and high-tech scans get reimbursed very well, while providing support to patients near the end of life doesn't. And healthcare is a business, so you might notice there's a massive cancer care center 100 feet from here, and there's, you guys have a massive palliative care and hospice center too, right? It's somewhere out in the county, I think. And that does trickle down, and we haven't done a good job of identifying patients near the end of life, supporting them, having the discussions anywhere along the continuum. That's improving, but we still have a ways to go. Just as one example, which I just got the data yesterday for our group at the medical or through BJC, looking at our huge population in St. Louis and the surrounding areas over the past 5 years. Of the patients who died, and these are patients over 65, only half had any hospice before death. And of those that had hospice, about 40%, their hospice length was less than 10 days. So I'm not a hospice provider, but I understand that being on hospice for 12 hours is not really how it's supposed to go. Those that were on hospice for longer than 10 days had fewer visits to the ER, fewer days in the hospital, higher satisfaction, reduced costs. We already know the benefits of hospice, and we know the benefits of having end-of-life discussions. But while everyone knows that, when you're a hospitalist on a busy day, when you're seeing, Devin can probably verify this, when you're seeing 20 patients and getting paged every 5 minutes, although you know that we should have a goals of care discussion with every patient that comes through the door, it's just not feasible. So one of the things that we've been discussing for a long time is, how do we, instead of just saying, hey, remember to do this for everybody, please, which is not an effective strategy, is how do we identify those patients who really need the discussion and ask our providers to focus their efforts on those 5% of patients who would really benefit from the discussion, while still asking them to do it for everybody, being realistic. And this is how we treat other diseases as well. Unfortunately, there's nothing available to do that. So we had to build it ourselves. So we worked with the geniuses over at the Institute for Informatics here, who designed a machine learning algorithm that takes all of the data from the electronic medical record, over 5,000 different pieces of data for each patient. Vital signs, demographics, laboratory values, medications, you name it, spits it into, and I'm not a computer scientist, but some sort of Rube Goldberg machine that spits out a risk for that patient of their chances of dying in the next month or entering hospice. So we were able, and it's scarily accurate. It's not perfect, but it's much better than what was available before, which is nothing. So that allows us, with a reasonable degree of accuracy, to identify the patients who really need that goals of care discussion, which again, everybody should be having anyway. And then instead of our current system, again, of asking people to remember to have the goals of care discussion or have the palliative care team talk to the patients while they're in the hospital, which usually happens 2 or 3 days too late, we're going to make it an opt-out system, because we know from behavioral economics that'll increase engagement significantly. So we started this up during the COVID crisis in about 6 weeks, which was not the original plan, because we had started this work before COVID, but the system asked us to do it more quickly, and we did. It went live at Missouri Baptist Hospital in Barnes in December 2020, and then 6 more BJC hospitals last year. And it's gone remarkably well. So we send alerts to the providers for hospitalized patients who are high risk that have never had the discussion. We were hoping that the engagement rate from the hospitalists and other providers would be 25%, which is about benchmark nationally for these sorts of projects. We're currently sitting at 90%, and that's been stable for over a year, which I think demonstrates that the hospitalists and other providers understand that this is important, as well as that we've done a fairly good job in filtering out the alerts that aren't that informative. We've got some preliminary data. This hasn't been published yet, but from what we've seen so far, the goals of care discussions have increased from 15% to 55%. So a 4-fold increase in goals of care discussions for these high-risk patients, which is phenomenal. And it turns out almost a quarter of these patients, and this is again, when they come into the hospital before they're decompensating, not in the ICU, just sitting on the hospital wards, almost a quarter of the patients, when asked, say, no, I don't want invasive treatments if I get sick. I don't want CPR. I don't want intubation. So the goal of this project was not to switch everybody to, that limited code, but it just turns out, that's just a demonstration that there was an unmet need. If a quarter of patients, we had the wrong assumption for what they would want, and when we ask them, they tell us, no, that's not what I want, it just means we weren't asking it ahead of time. So that's been the first phase of our project. We've had some generous donors who are supporting us, and we're trying to expand it now. We're getting back to our original goal, which is to do this in the primary care and outpatient offices before the patient even shows up to the hospital. We know that's the right place to do it, with somebody who already knows the patient when they have time to discuss it with their family. So that's rolled out across BJC 3 weeks ago. So more to come on that. And there's no lack of interesting places we could take this, predicting mortality out to a year on discharge, or how do we identify families and caregivers who need the support, providing support in the home. So there's a million different ways we could take this that we're very excited about. And so more to come about this. But yeah, that's where we're at now. So I'll stop there. Happy to answer any questions either now or after the event.
Great, thanks. Nathan? Questions? Yes.
Your conversation. Oh, sorry. Is that typically then palliative care is doing that, or the actual like hospitalist, or do you know the breakdown of
Yeah,
that?
so we send them a message, and by we, I mean, there's a person at each hospital who sends them a message. I do it at Missouri Baptist. I send them a message that says, this patient is potentially high risk. They've never had a goals of care discussion. Would you like to do it? Would you like us to have palliative care do it? Or do you think it's unnecessary, and why? We had expected that they would ask palliative care to do it a majority of the time, again, because they're busy. But as it turns out, about 3/4 of the time, the hospitalist or other provider does it themselves.
Okay.
And that's been really, a positive thing that we've seen. So about 1/4 of the time, the palliative care team, they ask them to come on board.
Okay. And then a second question is, as far as in the outpatient setting,
Yeah.
you're saying you're doing the alert. So is that same system go to them to know the prognosis, or, I mean, you said like the algorithm or whatever
Yeah.
is inpatient chart. How does that work?
Yeah, so in the outpatient space, we're predicting the risk of dying in the next 12 months.
Okay.
And same thing, if it's a high-risk patient who's never had a goals of care discussion documented anywhere, we send a message to the primary care provider before their upcoming appointment and ask them to discuss advanced care planning at their upcoming appointment. That's more challenging, as you might imagine, at a typical 15 or 30-minute appointment when you've got upwards of 5 or 10 things to address, also having that discussion. So we're currently trying to build the system around that to make it effective.
Okay, thank you.
Sure.
So in the back row.
Is there any, I'm just returning to Missouri, years out of state. Is there any move in Missouri to develop a pulse or a MOLS system?
So for those who don't know, that's the out of hospital code status order. So right now, if you come to Missouri Baptist and you say, no, I wouldn't want intubation or CPR, as soon as you leave the door, that is waived. And you have to redo that if you go to Mercy or SSM. There is what they call a TPOP form, transferable patient order of preference. I don't know. But unfortunately, it's been held up by the state and some of the Catholic health systems. So currently there's not. I mean, there is a form that we all have been filling out, but whether or not it's legally binding is unclear at this time. But a TPOPP.
And we have one in the back row, please.
Did you provide any sort of training or education for providers who are participating in these discussions?
Yeah, and the training they get, you're about to see too.
What a great transition, right?
Nancy? It might come right down there.
And we can talk about it later. Thank you, Dr. Moore. This is so fascinating. But if I'm a provider and I get a thing that says, Miss Jones' chances of survival are pretty slim for the next month, isn't it like, aren't there a lot of other things I'm worried about? Like, what if I said, whoa, you're kidding? What's going on? I mean, it seems like advanced care planning is in there, but doesn't that evoke a lot of questions in people's minds as well?
It's not a surprise for most of these
Never,
patients.
okay, that's what
Yeah.
what
I mean,
that
we tell them-
normally looks
We tell
like.
them, this algorithm's not perfect. If this doesn't match with what you're seeing with your own eyes, right? So trust your own judgment. For most people, it's just a reminder. You're already dealing with their kidney failure, liver failure, heart failure, dementia. You just forgot to have that goals of care discussion. And they're like, oh yes, you're right. I didn't have a chance to do that. That's what most folks have told us. It's not like, a healthy 40-year-old comes in for a toenail infection and we say they're going to die in 30 days, in which case, yes, they would be asking a lot of questions. I'll give you an example of one that I saw yesterday, a 97-year-old man, dementia, advanced cancer, 5 ER visits and 3 admissions in the past year. So this is not a surprise. The surprise is nobody's ever talked to him about goals of care.
I guess I'm just wondering, couldn't this make care better in lots of ways,
Yes.
maybe? And you're saying maybe not, but I got it. Thank you.
Yes, we're hopeful.
Gotcha.
So Dr. Moore, just for the audience, talk just for a second about the outpatient model and about how long in advance that predicts.
Yeah, so that the outpatient model predicts risk of dying in the next 12 months. So that should give people, we're hoping to give enough lead time where patients can have the discussion with their providers, have the discussion with their family, and then discuss when their health status and functional status declines, what they would want ahead of time, instead of trying to figure that out at 2 a.m. in the emergency room. We know planning ahead, there's been multiple studies that show, again, reduced utilization, reduced healthcare spending, improved satisfaction for patients and families. So it's one of the few things in healthcare that everybody wins. And then the hospitals get to use those resources for patients who have a greater expectation of recovery, since everybody's stretched so thin these days. So, you know, in theory, it works great, and other places have demonstrated various parts of it. So we're hoping to bring it all together here at the same time.
Okay. Thanks, Nathan. And our fourth and final presenter is Dr. Devin Odom. Dr. Odom is currently completing a fellowship in palliative medicine. He began working with Vital Talk, which is a nonprofit helping medical providers build skills and confidence in difficult conversations and end-of-life care. He is now the director of the BJC Communication Skills Academy and developed the communication skills curriculum for the internal medicine residency program. Working closely with the Standardized Patient Center at WashU, Dr. Odom trains actors to portray patients in realistic encounters and facilitates interactive small groups in experiential learning sessions. And you'll see an example of that today. He's dedicated his early career to making advanced care planning conversations more approachable for every provider and adapting our electronic medical record to make these important conversations more effective. Dr. Odom?
Thanks, Brian. So after a perfect segue from the back row about what we're asking, please, our doctors to do, we want to make sure that they actually have some skills and some confidence to have these difficult conversations. So I want to talk to you a little bit about how we practice medicine, okay? So I want you to imagine the hardest, most complicated, most stressful part of your job. There's a mixed audience here. Not everybody here is in clinical medicine, so maybe it's a big meeting you're preparing for, or you're getting ready to go talk to a pretty disgruntled customer, right? Now, this next part might not be very difficult for you to imagine, but you have no training for what we're talking about here, right? That's maybe a little bit scary, right? Now, our doctors here in the hospital are having difficult conversations with patients every single day, difficult new diagnoses, the unknown of an advanced care planning conversation and what the future holds, or the death of a loved one. And we're asking our providers to now have more of these conversations, and a lot of our providers may have a lot of good skills that they put to use over the years, that they've honed over decades of practice in the hospital, but a lot of us don't, or we don't feel confident in those skills to know that whenever we're saying, yeah, I'll do that, that it's the right answer, right? So we're going to talk a little bit about how we do that and what our practice actually looks like. What I'm doing right now is wrong. Traditional teaching is lecture-based, right? I stand here as an expert and I tell you what I know, right? It's designed to fix some sort of problem that we have seen in our community and our patients, and we're trying to address it head on, right, with an expert who's there to talk to you. It tends to be somewhat linear, right? I'm going to teach you X, and then you're going to go and do Y, and hopefully we're going to see Z, or maybe we have to backtrack and do something different. But it's anticipatory that you're going to need to know these skills or do this thing at some point in the future, right? And again, as I said before, it's also designed to be a teacher knows best sort of model, right? There's someone standing there who tells you what you need to know, what you need to do, and you're going to model that for other people. But a lot of you have probably experienced a different sort of teaching, right? And pedagogical theory over the last few years has really helped us to advance our teaching model, but professionals are a different animal in some cases, right? So it needs to be self-directed. We know what we need in some cases, and we've experienced it, so how can we lead or pilot this ship? We have tools. We need to know how to use them. So it's not necessarily about fixing a problem. It's saying, what tools do I have to fix these problems? And when are they going to be important? It's more dynamic. There's more open-ended options whenever you're doing something through experience. And it meets a practical need when you are there in the moment and you realize what's in front of you. And the last part here, I think, is most important. It's what I'm going to talk about next. It's respecting the learner. It's respecting the professional who's in front of you and what they already know and can bring to the table so that you can build on that. and expand their toolbox. So what are the principles of teaching this sort of thing? When you're talking to professionals and you're talking about these difficult conversations, you need Vegas rules, right? I mean, you need to have a safe place where you can practice these things, where you can put yourself out there, you can try new things, feel a little uncomfortable, and it'd be okay. So we try to develop a small group where learners can observe, where we can practice, where we can feel uncomfortable, and it's okay. And you can gain confidence in that environment. We focus a lot on positive reinforcement because the skills that all of our providers have honed over the last few years in many cases are excellent. And I want to highlight that because medical training is the opposite of that. There's a problem. You did something wrong. We have to fix this. But really, you're pretty awesome. And we need to highlight that. We also want to give an opportunity for people to highlight new skills, try something new, get immediate feedback, right, on what they're doing and what the outcome actually is. And as Brian mentioned earlier, I do some teaching for Vital Talk nationally, and I'm really honored that we can bring this sort of training here to our community. If you're interested in what Vital Talk is, it essentially is a nonprofit of clinicians who understand the importance of this sort of thing and understand that these skills can be taught, can be practiced, can be learned, the same as anything else that we learn in medicine. You can go to vitaltalk.org to learn a little bit more about that if you're interested. So the format that we set up is for providers. It's a small group. There's 5 or 6 clinicians who are there, nurse practitioners, doctors, PAs. There is an opening didactic because it's hard to get away from all of this. We want to make sure that we're all speaking the same language when we're talking about the communication skills that we're addressing. When we're talking about advanced care planning, what is the language we're using? What are we actually here to do? And then we meet 2 SPs, 2 simulated patients, and we do some cases. We interact with them, we talk with them, and the group participates. We talk in advance about how we're going to do timeouts, planned stoppages in the conversation so that we can debrief what's going on. We can talk about next steps. We can talk about what's going on that's really awesome in the conversation that they're already having. And then at the very end, we talk a little bit about the EMR tools in Epic that we can use to document these conversations so they're not just wasted words. You're not having a wonderful conversation and then it's a beautiful experience and then it's lost to the ether of the next provider who meets them. How can you pay it forward to your colleagues so that they can start where you were and move the conversation forward? How do you change the culture of medicine so that we expect to see that just as much as we expect to see the reasoning behind why they had renal failure? So what is a standardized simulated patient? An SP in the traditional sense is a standardized patient, right? Something that you would use to judge what bar everybody needs to come up to, right? Everybody needs a certain level of skill, so what's the standard? It tends to be scripted. It tends to be focused on a particular task that you're asking the person to practice and do. It tends to be driven by some sort of data, some type of impetus that started the conversation. And it tends to involve kind of a set way forward. There's a right way to do it. You just need to figure out what that key is, and then you can move forward and you can accomplish that task. But a simulated patient is a little bit different, right? It's not based on a script. It's based on a biography. It's based on a personality. It's based on someone's emotional state, their spirituality, their disease process. And it's improvisational. And the actors in our SP Center, and you'll meet one in just a few minutes, are outstanding at this. It's process focused. The conversation itself is actually the goal, not the endpoint. And it's driven by the emotions of these difficult diagnoses. And it just understands that there's many ways forward. Everyone is different. There's no right answer for every particular person. There's no right way of getting there for every provider having the conversation. So we're going to talk with one of our SPs on the right-hand side in just a few minutes. So what are the essential skills? I don't know why this slide is so small. There are lots of skills that we talk about in these sessions. We talk about plain language. How do we talk about disease for people? And how do we give that information clearly without doing what doctors like to do and tell stories? How do we remain curious without our own agenda? This is particularly important as we were hearing earlier about the cultural differences in our community. That cultural curiosity, I think, is one thing that we don't lean back on enough whenever we are uncomfortable in situations that seem different from our own experiences. We talk a lot about responding to emotion, hitting it head on, addressing it, bringing it to the front and center, rather than shying away from it and wondering what Pandora's box is underneath tears or laughter. We also talk a lot about the values and the goals that our patients have and how we can directly try to connect that with the care we can provide. How can we align our care with what our patients are telling us by connecting things without just putting things in some bucket of options without something to tie it down to. So we're going to demo this here, okay? We already have a small group here. This is our wonderful small group of professionals who are going to speak with our patient today. The ones who are going to do this already know this, so I'm not calling you up if we haven't already spoken and planned that you're going to participate in advance, so don't worry. I want you to note some of the things we're going to do today. So just pay attention to some of the educational aspects of the way this is structured. We want our learners to kind of guide themselves. We have to give you a framework to work from, but what do you need to work on? We want to positively reinforce the awesome stuff that you're already doing. In these conversations, you may not be aware of what you're saying because you're so ingrained in the conversation. So we need to pause and actually point it out. We're going to talk about how we present new opportunities and new paths forward, and then how we actually kind of bring it home so that it's something that made a difference, where you can see the impact, okay? And most of this is the job of a facilitator, to guide these conversations. So just pay attention to what you're noticing, okay? I'm going to move some chairs up here, and we're going to do a demo, and then after the demo, we'll open it up for you guys to ask some questions, okay? You volunteered early.
Oh.
All right. So group, thanks for being here today. We've already spent a lot of time this morning talking about advanced care planning and some of the skills that we can use in these conversations. And so I see I already have a volunteer who's in the seat. Brian, thank you for volunteering to talk with our first patient today. Thank you.
You bet.
Is it okay, now that you're already sitting here, you may not know what you've gotten yourself into. Can I tell you a little bit about our first patient and then see if you have any questions?
Please do.
Okay. So we're going to be meeting one of our patients in the hospital today. Her name is Billy Dunn, okay? She's 62 years old. She has a constellation of many medical problems. She's got high blood pressure, peripheral vascular disease, coronary disease. She's had multiple stents placed for her heart disease. She has diabetes, she's on insulin at home, and chronic kidney disease. We take care of a lot of patients with this constellation of medical problems in the hospital. She was just admitted to the hospital yesterday morning after experiencing about a week of worsening fatigue and poor appetite. She slid out of the bed and she couldn't get up, but she was able to move herself over to the bedside table where she could call EMS, who came to the house and brought her into the hospital. Labs in the ER showed she had a creatinine that was higher. Her kidney function is not very good. It's about double what it was before. And her albumin, which shows us her nutritional state, how well she may have been eating over the last few weeks, was also very low. Her A1C, which tells us how bad her diabetes is, was 10.8, which is at least 2 times the upper limit of what we would hope to see. She was last hospitalized about 3 months ago. She had a leg infection from her diabetes. It was not healing well. They talked about surgery, and the only option from the surgeons was to take off her foot, and she said no. And she went back home. It looks like she's been dressing the wound well. In the ER, vital signs were normal other than those lab changes. And when physical therapy came by to see her this morning, the note just says she said she was too tired and couldn't really participate. Overall, she's just kind of showing signs of frailty, that one little straw could really tip the balance. So she's not really been out of bed yet today. And in the wonderful segue we got this morning from Dr. Moore, you get this message that says, hey, Miss Dunn looks pretty sick. Seems like a pretty good chance that something bad could happen in the next months or so. Would you consider having a goals of care conversation with her to talk about her advanced care plan? And Brian, you said yeah. Actually, you said hell yeah, because I love doing this and we're gonna get at it, all right? You did say that, right?
I did say that.
You did say that.
I did say
okay.
that.
Brian, do you have any questions about that case? Any medical questions or anything like that?
I don't think so. It's pretty comprehensive. She's not
Yeah.
doing well.
No, she's not. And I'm sure you've taken care of people like Billy a lot of times in the
Many,
hospital.
many.
Now, we talked a lot this morning about some of the skills, some of the things that we can focus on in an advanced care planning conversation. Do you have an idea for what you'd like to work on in this conversation when you just kind of hear about it from the outside?
I think I want to know more about where she's at, what she understands about her situation now that she's in the hospital.
Good. So I want you to focus on that as much as you can. Okay, we're going to try to get as much understanding as we can about her situation, what she knows. And group, I want you guys to really pay attention too. You all have notebooks. I want you to write some notes down. I want you to pay attention to the words he's saying, because we're going to stop the conversation at some point. And I want to point out the awesome stuff that Brian's doing. Okay. I saw that little smirk there.
Yeah, I'm not so sure.
I want to remind you too that we can time out at any point. Okay, you can time out whenever you did do something really awesome and you want to make sure that we all saw it and know about it. Okay, you can also time out if you're not really sure what to say. If you need some help and you want to get some help from the group. Okay, I might time out too for the same reason when you're really rocking it, or if we need to kind of pause and see where we're headed.
Okay,
does that sound okay?
I'm with you.
All right, you ready, Brian?
Ready.
Okay, you can start talking with Billy whenever you're ready.
All right.
Yeah.
Good morning, Ms. Dunn. I'm Dr. Carpenter. I'm the hospitalist here who's in charge of helping you through your hospital stay. I'm the person who's going to be directing your care. I'll be working with other staff, other members of the team. But if you have questions or you have information that you need, let the nurses know to contact me. I'm here to help you through this process. All right?
Okay.
So I wanted to start out this morning by hearing from you about your understanding of your medical condition right now.
Well, I know I have a lot of things, but I also know that I work really, really hard to do everything that you guys tell me to do. But this past week, I went to get out of bed to use the bathroom, and I slid down to the floor. It's like my legs just gave out. And I got stuck there, and I managed to be able to call in and to have you guys come and get me and bring me here.
That sounds like it was a very difficult situation for you. I'm sorry to hear about that.
Yeah.
It sounds like you're very upset about what's been going on over the last few days.
Yeah, because I feel like I'm doing the best that I can, but I just don't know what happened for me to get so weak this week so that I can't even get out of bed to use the bathroom.
You're not even sure exactly what's happened. Why are you so weak lately?
Right, yeah.
We're going to try to find that out. We're going to try to figure out what's been going on, why you seem to be worse than you were, why it's been harder for you to do the things that you need to do at home.
Okay.
But I hear that this has been very upsetting
It has.
for you.
It has.
And we've got some plans and some steps we can take, things that we're going to look into and investigate
Okay.
to see what we can find out and make a plan moving forward so that we can help you in the best way that we can. Does that sound all right?
Yeah.
Would it be okay if I went ahead and told you about some of those plans and those steps that we might take?
Sure.
All right. Okay, I'm timing out because I don't know where I'm going next.
Oh. Okay. All right. So yeah, let's time out. How is it going?
It's going okay, I think. I'm trying to listen. I'm trying to be patient. She's getting upset, and that's wigging me out a little bit because I'm not really sure where she's coming from and how to respond to that.
Let's put that aside for just a minute, because
Okay.
I noticed that she was getting upset there.
Yeah.
I think you did a really good job at addressing that. I want to focus first, though, Brian, on what's going awesome in this conversation, because you were doing some amazing things to make sure that you're on the same page with her, and I want to make sure that you're recognizing that. Is there anything in your mind that you think you did really, really well?
Well, I tried to be kind of slow and not rush things.
Yeah.
So put some pauses in there to let her just kind of sit with whatever she's feeling and let me know what she's thinking, what's going through her head. So I think I tried to do a good job at pacing.
I think the pacing was fantastic. You were right there with her, matching that one-to-one. It was really, really good. Can we go to the group? I'm interested to see what the group's doing.
Yeah.
Group, tell Brian what he's doing really well. Yeah, Karla.
So I thought he noticed that the patient was feeling upset and named that emotion. And that seemed a really powerful moment in that encounter.
Yeah. Thank you, Karla. You're right. Yeah, you named her emotion, what she was feeling there. That's one of the things we talked about this morning, right? When you recognize those emotions, just calling them out for what they are, telling her that this is important, that I'm recognizing this, I'm noticing this, and it's important that we talk about it. Thank you. That was really, really good. I also really like the very beginning of the conversation where you connected yourself to her care perfectly. You told her what your role was with the team, how they could get in touch with you, how you're going to be available, and partnering with her, like literally from the word go. You were her partner, and I thought you did a wonderful job in that conversation. Now, when I timed you out, you said you weren't so sure, you were getting a little bit wigged out, I think was the word you used. Why were you getting wigged out right there?
There was a lot of emotion coming up, and I'm still not sure exactly all the details about what she knows about what's going on and where she might be headed next in terms of care plan.
Gotcha. So how are we going to be able to talk about next steps with her? You asked for permission, I think, to move forward, right? But what in your mind is where this is headed? What do you think is possible for her when you're looking forward in her medical care?
Well, she's got this wound that hasn't been healing. So I think one concern might be that might be problematic, that she might need, maybe she'll need an amputation or something equally aggressive, and that maybe she'll need to go to rehab rather than back home. So I think that there's a trajectory here that I'm not sure she's really anticipated or thought about yet.
Gotcha. Okay. So when we're thinking about how we can kind of move forward to the next part of that conversation, do you have an idea of what you'd like to try to say next, or should we go to the group?
Let's go to the group.
Okay, so group, we have an idea in our mind of what we think needs to happen in this conversation, right? We think that she's may need an amputation, right? She may need to go to a skilled nursing facility or something like that. How, when she's kind of giving us this bit of resistance and these emotions are coming up to play, how do you think we could move forward? Do you have any suggestions? What do you think? Yeah, Patrick.
So if she asks us about the rehab, and she brings up that emotion, we could ask, what concerns you about the rehab, and kind of drill down into that.
Yeah. So what's her perspective, right?
Exactly.
Yeah. What else? Yeah.
I find myself curious about sort of what normal looks like at home. And so I might ask something like, it sounds like there's a lot that's been going on at home. Can you tell me how things were going before you had to come to the hospital?
Right. So a little bit more about the perspective of what normal looks like for her at home. Right. Yeah.
Want to know what her goals are.
Yeah. So what?
We have an idea of what she needs, but that may not be concordant with
With what
she
she
would rather
wants.
die than have an amputation.
Yeah, that might be true, right? So Brian, what do you think? We got three options, right, to kind of think about next steps. So Patrick's suggestion was, when you're thinking about maybe needing to go to a rehab, what do you know about that? What do you think that would be like for you? Karla's suggestion was, well, let's go back a little bit, right? What's normal like for you? Tell me about what things were like before you came into the hospital. And then I'd like your suggestion too, like how do we actually figure out what her goals might be in this conversation? Now, keep in mind, we don't have to go all the way there. We've got a big group. We're going to carry this conversation forward. We're just getting started. But do one of those things seem to resonate with you?
Well, I know that she said that she had the thing that brought her into the hospital is she slipped out of bed and felt too weak and had to call EMS. So I'm kind of like interested in knowing more about what was going on at home before she came in, and that backstory a little bit, I'd like to know more about.
So we need more of the backstory, I guess, before we can really figure out how to connect a plan for what's going to be
the
necessary.
future.
So can we go back into the conversation? Is that okay?
Sure.
I want to go back into the conversation, Billy, where you guys were getting somewhat emotional, right? You were talking about what was going on at home. I don't remember exactly what you said there, but it was clear that things weren't going well. Can you start in that general area?
Sure.
Yeah, start whenever you're ready.
I mean, I feel like I'm doing everything I can, but I tried to get out of bed like I always do, and my legs just kind of gave out from under me.
And that was something that was new. You'd never experienced that kind of weakness before.
No, nothing like that before.
And it sounds like that scared you.
Yeah.
What was going on at home? Tell me a little bit more about what life has been like for you before you came into the hospital.
Well, I just can't be sick right now. I just got too much to do. husband, he's had a hip replacement surgery and he is finally getting out of rehab after weeks of them saying that he was going to come home. And there's no one to take care of him but me. And so I have to arrange the bathroom differently. I'm supposed to do something by the front door to be able to get his walker in. I got to get the bed moved somehow. And so I was working really hard to get all this stuff ready for him. And I don't know, maybe I just wasn't taking as good care of myself as normal, but again, I just don't think maybe not eating for a couple of days should make it so that, I can't get out of bed anymore. I can't, I gotta be there for him.
It sounds like you have a lot of responsibilities, and the idea of getting sick yourself makes you wonder what's going to happen to my husband and other things that have to be taken care of at the house.
Yeah, there's just no time.
Let's time out. How'd it go, Brian?
I think I understand much better that there is a lot of stuff going on that I wasn't aware of.
Yeah.
And so if I need to be able to think about what our plan is for her moving forward, I need to be aware of all of that stuff that I'm just learning about now.
Right. Before we start talking about a plan, right, we need to know what her responsibilities are, right? I think she just basically laid out for you what a lot of her goals are, what her values are with her family responsibilities. What did you do to get that?
I asked her a question about what was going on at home, rather than just telling her what we were going to do.
Right. We come in with our own agendas a lot of times, right? And we want to tell them what we're going to do to fix a problem, but sometimes we just have to pause and say, wait, what do you know about what's going on? Yeah. The next time you meet Billy in the hospital, one of your 20 patients, what are you going to do differently?
I'm going to slow things down and try to learn more about the situation from the patient's perspective.
Okay, good. Thanks, Brian. Thank you. All right, you're out of the hot seat. Okay. So at this point in the encounter, we would swap and someone else would come up and take this conversation moving forward with all the awesome stuff that Brian has been doing. This is an advanced care planning conversation done with groupthink rather than making someone do it all together. And the feedback we get from the group is vital. We steal from each other all the time, seeing things that someone else has tried that I actually would want to try, to learn new words, because a lot of times in clinical practice after training, it's independent and we don't get the opportunity to actually learn from our colleagues in an interactive situation like this. So thank you guys. Thank you group. Thank you, Brian. And thank you to Billy Dunn. This is not Billy. Her name is Michelle Hand. She's a wonderful actress from our SP Center. I'm going to ask you actually if you want to come back up here, because with our question and answering, I want you guys to be able to ask questions of all of us, both the learner who is sitting here and what it felt like for him in this hot seat, our actor who's portraying this role, and me, if you have any questions for me too.
Great. Michelle and Devin, you can take one of these seats if you like.
Oh, sure. Great.
Yeah. And I've been reminded that if you have a question, we're going to pause and make sure the microphone gets to you so that our folks on Zoom can hear the good questions that you're asking as well. So maybe we'll start out with some questions that you have for Michelle or Devin about the simulated patient work that they're doing. Yes, we got one over here.
So this is actually not a question, but just wanted to say thank you for doing all of this. I've been a social worker for over 20 years, and this is stuff we do all the time as social workers. I'm not super brilliant on the medicine side of things, but this personal interaction is so important. So I thank you. I have some people I would love for you to come teach if you guys are okay with it. But yes, thank you very much. Super important work. Thank you.
Thank you for your work, because a lot of times these conversations are not done by providers. They're done by our case managers, our social workers, our chaplains, our other vital team members. And you're bearing the brunt of this. And whenever we get these messages that says you should consider having this conversation, it doesn't just then become the responsibility of the clinician, it's the responsibility of the entire team. And so your work is essential too. And I'd love to come and talk with you guys. I do talk about advanced care planning with some of our social workers and case managers as well, just so we're all speaking the same language. I think that's vital too. So thank you. Yeah.
My question is, these talks are just so helpful. And I feel like I'm a nurse practitioner, palliative care nurse practitioner. And I feel like a lot of us have had this training and have even participated in groups with SPs, and they're so helpful. And it really empowers us to have these conversations better. But I feel like every time I sit at something like this, I learn new information and I get reminded of the tools that didn't particularly stick in my mind.
Yeah.
And I'm just wondering, how often you feel it's necessary to retrain people and to redo this, because it's not just a one-time thing. It's really like an ongoing education that needs to happen for people that are encountering patients with serious illness.
You're asking the right question. And I want everyone to ask themselves that same question, because ideally, I think everyone should at least do this once. The resources necessary, I think, make it difficult to reach every clinician. But the same way that we require our providers to get CME and learn about X disease or Y disease, why isn't this something that's the highest on their radar? I know a few reasons why, right? It tends to be uncomfortable. It tends to put us on the spot, and it tends to take a lot of resources to do it. But I think that those resources are necessary. Yeah. Yeah. You're exactly right. Spread that message, please. I want everyone to be able to do this as often as they would like to. This isn't the sort of thing I think that can be placed on someone to say, "Ooh, you should do that. You should do that." Yes, everyone should do that, but I think everyone needs to feel like it's important for them as well. And so I hope that we can build this academy into something bigger, with more vital talk-minded folks who can lead these sessions.
Devin, we've had a question come in from one of our Zoom participants about this. Given the increasing amount of communication between patients and providers that happens over the phone, or even through messaging on patient portals, are there ways in which the simulated patient teaching model could be adapted in order for providers to practice phone-based or message-based communication with patients?
Yeah. So just to give you an example, during the COVID, well, we're still in this. I said during it, it's like as though it's over. When our policies in the hospital restricted visitors significantly, this was a major burden, both on our patients, but also our providers in having these conversations. And so one of the cases that we developed was a phone call with a family member who could not come into the hospital to discuss their loved one who was ill from a COVID diagnosis. And so we did practice some of that with our residents. I think that there are more opportunities for us to practice this in a virtual environment. There are other challenges that come along with that type of group engagement. And whenever we're documenting these conversations in Epic, we actually have the benefit now of some pandemic rules with our government that allows us to bill for these conversations and document them in Epic through the end of this year. And we're hopeful that we'll have a little bit more leniency in having these conversations and putting them in our EMR long-term once those rules and regulations have not just expired, but hopefully been extended. Yes, thank you.
I had a question. I was just doing a panel or something with some first-year med school students at WashU last week, and they were off after that to go do something with an actor, and I guess learning, something on how to treat a patient. Do you know if they use this versus the standardized, model? Because I think it's such a great learning model for them.
I think one of the good things about our education and our medical school here is things are moving more in this direction. This experiential learning is something that our elementary teachers may have known for decades, but is somehow now only filtering up to the higher levels of education. Our SPs, and she may be able to speak more about her experience and other parts of her work, are moving more out of the simulated patients, out of the standardized patient model, more into the simulated patient model, just to give people a bit more flexibility, more realism. And even our testing modules are now changing too. We used to always have to go and meet several of these standardized patients, but that's now gone by the wayside as one benefit, if there are not many, of the COVID pandemic. Yeah.
Joan?
Brian, you did a great job. I am so excited to see this come here, and I have a feeling Dr. White had something to do with that. But this is really great. And Billy, you did a really good job. You did a really good job. So my question is, I do not work in the hospital setting. I work in the community doing advanced care planning, which is different because in the hospital setting, you have the whole team, the doctor, the nurse, the social worker, to work with patients on their advanced care planning. But in the community, and we're doing advanced care planning presentations at the library, it's a different story. And I noticed that you, Dr. Odom, did not have your email address on your contact information. So if you could
Yeah.
please share that, because I would like to have a conversation with you about advanced care planning in the community.
Absolutely. Oversight on my part. I'm not hiding.
Thank you.
I don't want to be hiding. In fact, everyone who sits in my sessions, I give them an email address and I say, the next time you talk to a patient, you're having some questions or challenges, email me. And I broke my own rule. So my email address is dodom, DODOM, @worcester.edu. And I am a hospitalist, so sometimes I'm on service for 7 days and I'm really busy, and sometimes I'm off for 7 days and doing this. So if I don't get back to you immediately, then pardon me, I will get to you.
Patrick, did you want to jump in?
Yeah, I just want to say one of the funniest things about this is a lot of times the doctors who are the very worst at this think they are the very best. So the providers that think they're great or terrible. There is nothing funnier than when they do these sessions with the standardized patient, because the standardized patients are trained to get upset the worse they're doing. And they keep trying to like talk louder and say the exact same thing. And it is so funny. And a lot of them will get the light bulb moment and go, oh my gosh, you know, I've been doing this for 30 years and doing it badly. And they never had any idea. So this is just something new to us that we've been doing here, and kind of building in with what Dr. Moore's doing, identifying all these really sick patients. We're one of the first healthcare systems in the country to pull it all together, and nobody's achieving the type of rates that we are for catching that proportion of high-risk patients. So
best place to die in the United States. I told you.
So you guys are all on the end of life spectrum of the clinical care teams. Are there opportunities or models to integrate with other disciplines within your field, within clinical care, to make this kind of conversation happen earlier before people get sick?
I can speak to that a little bit, but I think that might be a good transition, I think, to other members of our panel as well. Currently, these sessions are being offered for hospitalists at our various hospitals. However, as you can imagine, there is a need across multiple specialties. Our residency program, we've been doing this very robust 4 half-day sessions for all of our residents during the course of their training. I meet with the oncology fellows as well, and we do some cases that have been very impactful. I think you may have assisted with some of those, Michelle. We're also hoping to move and talk more to our CHF, our heart failure physicians, who have a lot of these conversations with their patients. Our critical care physicians as well, I think, are another good group to come to. All providers need to be participating in these conversations, not just the medical specialties. And so I look forward to engaging with as many different groups as I can to figure out what their needs are, developing cases that match what their clinical practice looks like, so that we can really hit their needs and hit the ground running.
I'd like to stick with this theme of communication and open this up, this next question, to the panel, and remind you that there are some microphones there. So please use your microphone if you'd like to chime in. This is a question from a listener on Zoom who says, in my experience of caring for patients under an in-home palliative program, patients there are often more reluctant to discuss end-of-life and advanced directives in the Black population. Do you have any suggestions on how to approach this hesitation? They'll turn it on in the back, Keisha, I think.
Perfect. Excellent question. I think that many communities have different ways of going about conversations. And part of that goes to having a workforce that looks like and comes from the community that you're serving. And so, you know, my question in response back to that is, is there a disconnect there between the culture of the patient and the culture of the clinician or the person that's in the house trying to deliver effective care? And so having a little bit of that curiosity that we talked about earlier and learning about their culture from a true curious place rather than a judgmental place could be helpful. And I think also the research that we're hoping to do here is to give more knowledge about different perspectives. I think one of the issues that we have currently in our research is that we are very well represented for white Americans, but not for everybody else. And so including people in research is a big part of understanding how best to serve people.
I just want to advocate, I suppose. This is kind of based on two recent experiences with a brother and a brother-in-law, both in their 70s, one married, one not. And the case managers at the hospital, it's been a while since I interacted with acute care. And, they didn't come in person. One was BJC, one was SSM, just saying the nursing care was impeccable in both places. But the case manager calls, talks to them on the phone. How many steps to get into the house? Do you have somebody that can cook for you? Do you have a primary care physician? Maybe there were 2 or 3 other questions. I think this is a core group because I think a lot of times people think, well, that was the advanced plan. That was the discharge plan. And I just feel like both the patient has to be educated in terms of what they would ask for. Neither of these men would ask for a thing if they just wanted to go home. But I do think if the case managers, they're so task oriented that they may not be able to have the conversations that you're simulating, but how do they get those conversations linked back to the patient? So I think there's a grant in there somewhere, but I would really advocate for that.
I just would like to ask, why are we waiting until their critical care? 18 and up should have advanced directives because who knows when that car accident's going to happen or that bus is going to get you on the curb.
That's a great point. And our friend Joan, who works with the folks at the Gateway Coalition, are trying to do a lot of public education and communication about how important it is. I was talking yesterday with a group of college students. We filled out an advanced care plan in class yesterday. So this needs to happen all over the place. Yes. Good question. Great question.
And just to speak to that too, that's one of the things we do talk about in some of our sessions is how do you normalize this conversation? How do you describe what it is we're even asking you, right? What are the plain language descriptions of an advanced care plan, right? And we could talk about that for a long time here, but that is one of the topics there when we're talking to a 19-year-old versus a 90-year-old.
And the other side of the coin is, in Illinois, we've been working on talking to people with disabilities so that they can understand what's going on in their life decisions.
Very important. Nancy?
Yeah, I'd like to go back and intersect Dr. White's work with Dr. Moore's work and Dr. Odom's. So we know that this the healthcare, the racism in our healthcare system ends up somehow with Black patients getting less pain medicine as example. How does Dr. Moore's algorithms correct that or play into that? And how does Dr. Odom's training correct that or play into it? Because we know it comes from somewhere that we're not even aware of. Well, we are aware of some, but not all.
I can start and then I'd love to give it over here, which is just to say all 4 of these are actually tied in. So Dr. Moore identifies them, Dr. Odom gets the providers to have that conversation skillfully. Dr. Washington uses that information to support the caregivers and get that information so that it is building things for us to check in on how those caregivers are doing. And then Dr. White is going to help us to make sure that we're catching those groups and reviewing that data to make sure that underserved groups are getting supported the right way. And maybe there's multiple ways we need to go after this. So we've got some ideas, but that's the 30,000 feet.
We're very cognizant because we know that algorithms can either reinforce existing bias and make it worse, or they can provide an objective measure and make it better. So that's one of the things that we thought about a lot when we were setting up the program, and we tested it multiple times to make sure that our algorithm was not biased either for or against particular subgroups, including by race. And luckily it's not. But that is one of the things that we're hoping this can do. You know, there are other clinical scoring systems in medicine that help to reduce bias by giving people objective measures. You know, for example, somebody with atrial fibrillation, there's a simple score to estimate their risk of stroke and clear guidelines as to which patients should be given blood thinners and which shouldn't. And that can help to reduce the individual bias by providers and patients to make the care more equitable across the different subgroups, including race. So we're hoping that this algorithm will prompt providers to provide the same level of care across groups, because we're not asking them to provide their own clinical intuition for each patient. We're reminding them for these high-risk patients, regardless of race, that this is something they need to do. Did that answer your question?
And Devin, is there anything within Vital Talk that tackles implicit bias or anything like that?
There are some things that tackle that directly. I have not been directly involved in the development of those things, so I do have to defer to my colleagues who are much more experts in that field than myself, and that's why this team is a diverse one. I will say that when we're developing these cases, we do factor some of those things into the biographies of the stories that we're telling. It's not something that's guaranteed to come up in the conversation or the context of those cases, and the cases are built such that we have some flexibility in who can portray those particular patients or roles. So they're not, and this is part of the other slide that you saw up there earlier, where, you know, in medicine, we are underrepresented, and unfortunately that tends to be true across our work. Even in our SP Center, we do sometimes struggle to find actors who represent minorities that we're caring for, so that the cases can also then be adapted accordingly. But one of the skills that we do focus on is that agenda-free curiosity, right? Where if we notice that there are differences culturally, racially, we are asking questions, wanting to know more, trying to explore those things in more detail, so that we don't put people into buckets or let our bias interrupt what we're recommending for people. And just by drawing attention to that curiosity, I think we can try to address some of those things, but that's not enough. So we need to work and do that better.
We've got time for one or two more questions, and I'm going to go back to a Zoom question that came in actually before our break. And this is a little bit more of a philosophical, systemic question. So it's open for anybody who wants to chime in on this. The participant said, we described the difference between hospice and palliative care. What is the difference between palliative care, which, you know, emphasizes aggressive symptom management, holistic, psychosocial, spiritual, everything, we're supposed to do it all. What is the difference between palliative care and regular medical care? Is there any hope of bringing palliative practices to regular care?
I'm happy to.
That's a Patrick question.
Okay. The first huge difference between palliative care and standard medical care is that we rely on a team approach. Historically in medicine, it's been very much on the provider, the physician or nurse practitioner. Palliative care has realized that does not address a person's whole illness. So when you're dealing with seriously ill patients, it's fine if you need sutures, right? It's fine if you've got something small. But when you're talking about a life-limiting illness, there are existential questions that come in. You know, there are a ton of social dynamics. There's a family that needs support. Palliative care pulls in that whole wraparound of services. And that, I think, is the secret to why we get such better outcomes and we're more effective, you know, at addressing the total person and their situation. We look at their family, we think about their home situation, we're thinking about social determinants of health. There's a lot of different pieces that get wrapped in.
But are you suggesting that regular medical care shouldn't be doing those things? Like
No,
in an ideal world?
I'm saying it doesn't. I'm saying right now, your regular doctor or nurse practitioner is not necessarily going to pull in. We were one of the best cardiology docs at addressing palliative care issues. We were laughing the other day at our palliative care grand rounds because he had never seen a cardiologist, and these are CHF docs that deal with end of life. He had never seen them engage a social worker or chaplain directly to pull it in to support patients and families. So in medicine, we don't use the team the way we could, and it's a huge limitation. And I don't know how soon that thinking about, you know, their whole situation, that'll get into mainstream medicine. But I can tell you, we've seen here that the more people see the outcomes, they say, what is that? How do I do that? And they start addressing a bigger part of their patients.
Okay, thank you. Thanks to the panelists as well. We got one more, Joan.
Just one comment about advanced care planning in the community versus in the hospital. In the community, there are so many myths and misconceptions about advanced care planning. And the other thing is there are so many different advanced care planning documents. You have the 5 wishes, you have the Missouri Bar, you have the bioethics group. So I think people are intimidated because the language in each one is different. Then you have the lawyers doing the living wills. Then people think the only way they can do their advance directive is by seeing a lawyer. So there's a lot. I know this conversation is about in the hospital, but it just dawned on me today that the community should really be, when I say community, I'm talking about Gateway End of Life Coalition, should be a part of any of your advanced care planning conversations or presentations. Thanks.
So much. I would like one more hand for this wonderful group of presenters. I know that I have learned so much today and I'm appreciating this work so much. I know we need to do more, obviously. We have more questions, we have more things to learn. So Patrick et al., you need to figure out how to keep doing this for this community. Thank you. Thank you all for coming to our Friedman Lecture. Please join us at other events. Please sign up for our newsletters. We hope to interact with you soon. Be well. Thank you.